Hi, this is Adam. Thanks for stopping by for the final presentation, which is a case study on respiratory acidosis and hypothyroidism. Stay tuned. Here we go. For this presentation, the objectives are as follows. At the end of this presentation, learners will be able to illustrate the past medical history, what would look like for a client with respiratory acidosis and hypothyroidism. Learners will be able to discuss the pathophysiology of the two disease processes as well as how they impact one another. Also be able to discuss medications the client would be able to be on for the conditions and any concerns with drug-to-drug interactions, as well as any age-related issues. You'll further review the overarching concepts of nursing practice impacted by the disease process, as well as identify the psychological social concerns related to the case study. I'd like to introduce you Karen Woodward. She is a 70-year-old woman. She's a retired newspaper reporter. She worked for 30 years. She occasionally writes and blogs and publishes some poetry that she likes to pencil out on the occasion. She currently is on disability, and that's been for the past 10 years. She was widowed for the past 15 years. Remember that mine accident? Well, her husband was one of the dozen that did not come back up. She has a daughter living in Boulder and a son who's full-time in Greece. She's estranged from her two sisters and her mother. I'd like to introduce to you Karen's health. She does have a family history of coronary artery disease, diabetes, dementia, chronic kidney disease, as well as Hashimoto's disease. Karen's past medical history is of depression and anxiety, bipolar 2, COPD, malnutrition, chronic pain, diabetes 2, as well as poor health planning. Karen currently smokes roughly 2 packs of cigarettes per day for the past 50 or so years. Currently, Karen has not been keeping up with seeing her doctor, but she has had some CHF issues where she was prescribed an ACE inhibitor as well as some Lasix. She does, for her COPD, use a CPAP at night and use an inhaler to help open up her lungs when she needs that, as well as her diabetes. Her diet's pretty much uncontrolled, as well as the metformin that she doesn't take. It's pretty much is what we would consider uncompliant. So let's take our thoughts about Karen. A couple questions I want to ask you that I'd like you to reflect upon before we go any farther. What's the relevant information here? And what are your thoughts on Karen's health? So if you're looking at this as a case study, what else would you want to know about Karen? And I did put in this last point to know that this is going in a certain direction. I just want to assure you of that. So I'll give you a moment here to pause, and we'll get back to our case study. All right, so today Karen woke up, she couldn't breathe. So she calls the ambulance, they come pick her up, and she presents to the hospital at the ED with severe shortness of breath and a 2-month history of increasing fatigue, pretty much falling asleep inappropriately, like at meals, riding in cars, and in the bathroom. When Karen got to the ED, she said she hasn't been feeling well for some time, and that she's continually short of breath, with this chronic non-productive cough and frequent headaches for the past several months. She's got this lower extremity edema, as well as a little bit of neuropathy as well. And she also mentioned that she gained some weight since her last doctor's appointment. Yet, she also says that she hasn't been to the doctor for 3 months. Last noted visit was more than 6 months ago, since she stopped seeing her PCP because, well, as Karen admitted, her PCP just didn't know what she was talking about. At this point, go ahead and make a little list of any additional questions about Karen and what's going on. We'll get back to that in a moment. When you're ready, we'll just hit play, and we'll continue on. No cute furry dog pictures, by the way. All right, after you made your list, I'm hoping that you wrote something down about physical examination, maybe labs, treatments. Well, let's hit all those coming up next. So Karen's voice is hoarse. She's continually clearing her throat with non-productive cough. She complains of shortness of breath and tightness of her chest. She had audible wheezing and was using accessory muscles for respiration. Coarse rails were present in both lungs. She's lethargic or oriented times 4 with a little bit of anxiety, nervousness, and looks overall disheveled. pallor of her skin and thin hair, generalized edema of her face, her hands, and her feet. Temperature is 100 degrees Fahrenheit, blood pressure is 162 over 90, heart rate's 102, respiration rate's 42 breaths a minute. Slow capillary refill with skin that is cool and slightly clammy with +2 pulses. Tendon reflexes are +2 and symmetric. Labs were drawn. White count looked like it was slightly elevated at 23,000. H&H was stable. CMP showed a glucose of 290. Kidneys, liver, and levels were good. Electrolytes were slightly low, but they were okay overall. ABG showed 7.8, 7.28 as a pH. CO2 is 50. O2 is 63. And bicarb is 45. And her chest X-ray showed moderately severe cardiomegaly, because she does have a big heart, and severe pulmonary edema. Anything jump out at you these labs? It should. Initial treatment, Karen was admitted to the hospital. She was treated with some bronchodilators, given some digoxin. She was also scheduled. She was given some furosemide as well as some broad spectrum antibiotics. And she was placed on 4 liters nasal cannula. All right, so I want you to grab your paper again, write down any additional questions you may have, maybe some additional assessment questions you want to check out. We'll be back in a second. With Karen having some respiratory issues, I think we'd want to check out, maybe see how if she's got any JVD or pursed lip breathing, if she's tripoding or having any nasal flaring, any kind of like additional accessory breathing going on, any kind of decreased in tactile primitus. Also, is she barrel chested or not? Or is there anything going on with her chest? How about like pulmonary lung functions, like spirometry, vital capacity, pulse ox? How's all that looking? We're also going to take a look here at maybe a COPD assessment test, which is called your CAT test. But overall, she's having no issues with her bowels voiding. She is menopause at 60, and interestingly enough, she is up from her last weight, which was 215. Now she's at 275. Other sorts of assessments I think you'd want to look into would be psychosocial concerns. It seems like there's something going on here with Karen. It's making her compliant with her medical treatment. Let's look at adherence. What do you think the issues could be with adherence with Karen? What are the dimensions here of adherence that are preventing Karen from finding quality health? It seems like there's a breakdown in the spectrum of adherence with the compliance of Karen's willingness to comply to the plan of care, the persistence of her ability to follow through, as well as the concordance or her ability to get along with her PCP. Something else that you want to touch on here is self-management. And just looking at the definition for self-management, I think it would help describe like where we need to go with Karen here, because self-management is the ability of individuals and the caregivers to engage in the daily tasks to require and maintain these healthy and well-being, to manage their physical, psychological, and behavior, emotional process of the disease based on their knowledge of the condition and its consequences, and why they need to follow the plan of care, or what happens when you don't. So with that said about the physiological ideas of Karen, what can we put together with our nursing diagnosis to help guide our care? So I just want you to take a moment, jot down a couple ideas, and we'll get back to that in a moment. All right, now that you came up with several ideas for nursing diagnosis, let's see how they compare with mine. Impaired gas exchange. Since this is on respiratory acidosis, I figured this was a good place to start. We're going to say this is related to altered oxygen supply as evidenced by the shortness of breath. For number 2, we'll say fatigue. This is related to poor physical state as evidenced by her increased lethargy. For number 3, we're going to say knowledge deficit. And this is going to be related to not following her plan of care as evidenced by her current health condition. And number 4, ineffective health management, related to complex health issues as evidenced by, again, her current health condition. So here we are, we're still at the hospital. We're trying to figure out what's going on with Karen, because she's just showing signs, additional signs that's not exclusive to respiratory issues. So what other labs would you want to draw? Well, let's take a look. Maybe we can grab an A1C since we know she does have diabetes. Just want to check this out. Maybe some blood cultures. Maybe see if our antibiotics are going the right way. EMP, EKG, flu swab, as well as a thyroid panel. Yeah, you see it. Over the next hour, Karen's clinical status has deteriorated. Uh-oh. Let's see what happens. So there's a change of mental status. When she came in, she was GCS of 13, and now she dropped to a GCS of an 8, a 215. So she was immediately intubated because remember, GCS of 8, you intubate. And she was ventilated. They drew a new ABG, and it came in to show that she was a pH of 7.14, CO2 is 80, O2 is 50, and bicarb of 45. So she's progressively gotten more acidotic, as well as a bump in her CO2. After Karen got settled in the ICU, some of her lab results have been trickling in. She does have an A1C of 9. Her thyroid panel did come back showing her T3 was at 58.8 as well as T4 was less than 1. And she was positive for the Haemophilus influenza. Good doctors and high quality nursing staff are taking a look here at the pathophysiology, trying to figure out what's going on with Karen. And we've kind of started to link up some of these reasons why she's not feeling so great these days. Pathophysiology of her conditions are going to be linked to her nutrition, the continual fatigue, the cognition, as well as gas exchange. This might actually be a condition like the chicken or the egg sort of thing, and maybe it really doesn't matter when it comes down to it, because now Karen's currently receiving the treatment that she actually needs. But I have them listed in this order, which may not be necessarily number 1 to number 4 in realm of like least to most important. However, I can tell you that when you have gas exchange that decreases, your cognition is going to decrease and you're going to become fatigued more easily. Your body and its nutrition level is going to decrease as well. You have some of these metabolic processes going on, and you're not, if you're just continually just consuming nothing but carbs, it is actually very easy to become malnourished, even though in Karen's case, she is obese. Now, if you're looking at hypothyroidism as well, how is that going to play into this picture? Karen's T3 and T4 levels were quite low, and as that relates into her initial assessment with her some of the swelling, some of the poor skin look, the pallor of her skin, as well as the thin hair, as well as the fatigue. This can all play into as well with like complications in the metabolic process, which will skew your body. So in Karen's case, she has the respiratory acidosis from like the poor gas exchange in her body because she has the COPD, which is preventing proper gas exchange in the alveoli. Then throw on top of that the hypothyroidism. It's no wonder that Karen's not able to take care of herself because she can't think clearly because she's just this overall mess with medically. So after Karen's last ABG, she earned herself, like I said, intubated as well as a trip to the ICU. So what I'd like you to do, grab a piece of paper and your pencil again. I'd like you to come up with several ideas, thinking like what is going to be how Karen's treatment is going to look at this point. Hit pause. Come on back when you're ready. All right, here we are. Let's see how your list compares to mine. So event changes we're setting. There was a change in vent settings for an acidotic ABG with low PO2. So what that means that her to combat this respiratory acidosis, she was giving more volume to her breath, as well as she was made to breathe faster on the ventilator to blow off that CO2, as well as to allow her body to oxygenate better. The treatment kind of looked like diuretics for the pulmonary edema, a steroid and bronchodilators for the respiratory acidosis, as well as the pulmonary edema. aggressive glucose management because you throw in the steroids with her out of control blood glucose. You're going to have to be aggressive with that treatment and antibiotics for her flu. I also want to say that Karen also did receive quality pulmonary toileting, though she was never prone or had any additional aggressive pulmonary treatments begun. She used a lot of percussion, a lot of vibration, as well as turning frequently to allow her body to oxygenate. So it took several weeks, but she did gradually improve, and she was liberated from the ventilator 2 weeks after she got in there without any further respiratory distress or complications. All in all, Karen did okay. So going home after Karen's stay at the hospital, she has some different medications that she received high quality education about. Starting with Synthroid, she was prescribed at 50 micrograms daily at bedtime. There was also the T3, the liothyroid, which she was not taking yet. This is on standby just in case that the Synthroid wasn't going to work. She was giving a short-acting beta agonist, albuterol. That's for her emergency inhaler, and that she can carry with her at all times and use when needed. She also has salmeterol for metered inhaler. That's 50 micrograms twice daily, and that's going to give her about 12 hours of improving her breathing. She's also given 40 milligrams one time daily of Lasix to keep fluid down in her body, and she's going to go home with supplemental oxygen. And for now, she's going to start with long-term oxygen therapy. Other medications that Karen's going to be prescribed is 1,000 milligrams of metformin once daily at the evening. She's also going to take an aspirin and a statin because she is at incredibly high risk for heart disease as well as stroke. And we're going to work on smoking cessation for Karen as well. So we're going to break down the medications a little bit. The first medication we're going to look at is Synthroid. It's a thyroid agent. The typical dosage is 25 to 50 micrograms a day, and it's adjusted every 6 to 8 weeks. Common side effects are what you could consider thyroid storming. It's hot flashes, fever, sensitivity, heat, sweating, headache, nervousness, irritability, nausea, changes in appetite or weight. Pharmacodynamics are usually to replace, or it's a supplemental therapy for hypothyroidism, any type. The pharmacokinetics, it's absorbed in the GI tract. It's a half-life of 4 to 6 weeks. It's broken down in the liver and excreted by the kidneys. And the interaction in the beers is none listed. The next medication for hypothyroidism is liothyroidine, which is also a thyroid agent. And to find out, this is a T3, which is 4 times more potent than T4. And the usual dosage is 25 milligrams daily. It's usually not considered the first line of treatment in hypothyroidism, but in Karen's case, we're going to have this on board just in case she needs something a little more. Same side effects as Synthroid, as well as the pharmacodynamics as well. This is also absorbed faster and has a shorter duration than Synthroid. It's metabolized in the liver, eliminating kidneys, and the half-life is 1 to 2 days. No interaction noted with the Beers criteria. Looking at pulmonary agents, salmeterol is a long-acting beta agonist. It's a selective beta-2 adrenergic agonist, and the typical dosage is 50 micrograms, one inhalation twice daily, every 12 hours. Common side effects, as listed there. Pharmacodynamics is a long-acting synthetic bronchodilator. Pharmacokinetics, it's effective in 30 minutes, 12 hours improvement over half a day. A half-life of 5.5 hours, and it's limited 60% in feces and 25% urine. And I could not find any interactions or anything listed for Beers criteria. Next medication is albuterol, which is a short-acting beta agonist, and this is 2 puffs every 4 to 6 hours as needed, not to exceed 12 inhalations in a 24-hour period. Common side effects is increased anxiety and possible cardiovascular issues. However, since this is the beta agonist, it works on other muscles beside the heart. It is a bronchodilator, and in the kinetics, it works to pretty much decrease the release of mediators from mast cells in the airways. So overall, it relaxes the smooth muscles from the trachea to the terminal bronchial tree, and interaction Beers criteria is none listed. So the next drug we have is for pulmonary status. It's furosemide or Lasix. It's a loop diuretic. Usual dose is 40 milligrams, um, and it can be repeated as needed. Side effects are dehydration, orthostatic hypotension, as well as electrolyte imbalance. Pharmacodynamics inhibits primary absorption of sodium chloride in the proximal and distal tubes, as well as the ascending loop of Henle. It's metabolized by the liver, half-life of 2 hours, and eliminated in the urine. The do need to be aware to monitor those susceptible to dehydration. Next medication is oxygen. It is a gas. Typical usual dosage is 2 liters, 15 hours a day for long-term oxygen therapy. Side effects are dry nose, hypercapnia in patients with COPD, as well as falls. And another common side effect is burns. Pharmacodynamics, reverse hypoxia. Pharmacokinetics, same. It just allows better oxygen within the cells. Interaction in beer is none, but needs to be reevaluated at 3 month time to ensure the therapy is indicated. And I spoke about burns. Something interesting is that I think it was 58% of patients started on long-term oxygen therapy continue to smoke after they are given oxygen therapy. So here we are. I'd like to give you a little update on Karen. 6 months later, she did find a new PCP. Her last one wasn't great. A bit of a bum, actually. She followed up with her PCP every 6 weeks until she got her T4 levels therapeutic, and she did not have to start the T3. She did lose 40 pounds. Her blood glucose remained controlled in less than 150 without insulin. She's able to decrease her smoking. However, she is still working on that, and unfortunately, she still is wearing her oxygen. Her overall mental status has improved. She's not feeling lethargic. Her colors return, and she's not feeling depressed. She actually adopted a big furry dog. She signed up for Kung Fu at the community center, and she started to fly fish with the new gentleman friend that she just met. So here we are. I know we've gone fast. We've covered a lot. I've given you this great story about Karen, but hang in there. We're almost there. As you can see, we got the recap. So let's talk about the objectives and compared to like what we learned. We illustrated her past medical history, and we found that her current medical history is connected to her being isolated, her family history, as well as current behaviors. And that's what's influenced her present medical status. We've discussed the pathophysiology of hypothyroidism as well as respiratory acidosis, and we've looked to see how COPD and hypothyroid affects people in their health. We also discussed the medications that Karen has been on for these conditions, and we discussed the Synthroid, the T4, the T3, the albuterol, the short-acting, the long-acting, the salmeterol, Lasix, and the supplemental oxygen. We've also reviewed the overarching nursing concepts of practice when we came up with the concepts of nutrition and fatigue, as well as the poor gas exchange, and this can all affect your cognition as well. Nursing diagnosis is the impaired gas exchange, the fatigue, knowledge deficit, as well as ineffective health management. And finally, the psychosocial concerns, which is the adherence and self-management for Karen. And with these, I believe that we have hit the objectives to this case study. I'd like you to take a look at your list, give yourself a big star at the top of that paper because you've done a great job with this case study. Well, that's it. Thanks for stopping in, working through this case study with me. I hope you enjoyed it as well as learned a little something, combination as well as the complexity of past medical history as well as current behaviors. Take care.